Well, I will date myself because our topic today is KRAS mutation, to say we were among the very first to identify and publish on identification of KRAS mutation in blood in the year 2004. So about 15 years ago.
It's quite incredible.
And we saw that after treatment, where the patient clinically responded, that the mutation disappeared from blood, and then that KRAS mutation came back. Yeah. So I think now we'll turn our attention specifically to KRAS. Let's move now toward how we test for KRAS. And this has changed quite a bit over the last few years. Ben, give us a little bit of a background about what was KRAS used for in the first place, and what do we use it for now?
What a change in the testing algorithm, or the importance of KRAS testing. You know, I'll take you back again to 12 to 15 years ago about, you know, my intro into lung cancer and where we were thinking KRAS was relevant or not. I mean, KRAS it is the most common mutation that we see in non-small cell lung cancer, and we were sometimes testing for it. You know, for me, as we started, you know, in the early or mid 2000s, you know, KRAS, as far as I can remember, was more showing lack of predictability to TKIs and some of the EGFR TKIs. So there was a running theme that patients who were KRAS, one, were EGFR TKI refractory, and this was when we were using TKIs for EGFR TKIs for all patients, not just EGFR mutations. And I think there was also some emerging data that KRAS portended worse outcome for patients. But in terms of treatment selection, it really wasn't, when I started, driving any sort of chemotherapy selection, because that's what we were using when I started. It was more when not to use EGFR-directed drugs, which, gosh, we've come so far to think that we were using these EGFR TKIs in all comers and looking at KRAS as some mutation that predicted lack of response or outcome to these drugs. I'm curious as to your you know, and so we've come a long way, obviously. KRAS is now a part of our comprehensive genomic profiling, and I can certainly give you some caveats to that now that these new drugs are coming out. You know, we test KRAS for everyone, and I don't think up until about a year ago, we realized that the subtype of KRAS mattered. You know, now we have some drugs that we'll talk about that are specific to KRAS G12C. And what that's forced me to do is that it has, you know, these patients who've been on chemotherapy for long periods of time, where the molecular testing was maybe done a year ago. Yes, I remember they had a KRAS, but I don't remember what subtype they had. And now that we have these new therapies, I've had to look back to see what subtype of KRAS they have and note it in my note that they do indeed have the right subtype that may make them eligible for clinical trials. So this is my evolution of both KRAS testing and my interpretation of KRAS utility during my career. How about you, David?
I agree with you. And KRAS initially was felt to be a rule out for EGFR, as you stated. We're actually, again, the first to say that patients with EGFR sensitizing mutations could have a concurrent KRAS mutation. We presented those data at ASCO, and the questioner from a large city in the East Coast said, well, that's impossible. You have a bad test. And then 2 years later, that same institution got up and presented their series, which showed that it could happen concurrently with other oncogenes, and probably has a worse prognosis than, let's say, EGFR by itself, just like p53. That being said, now that we have next generation sequencing, whether it's in tissue or in blood, you get KRAS. You don't have to ask for it. It's part of the package you get. And now, as you mentioned, more and more it's meaningful. Now we'll talk about it's meaningful because we now have some small molecule inhibitors, but it probably is also quite meaningful in terms of immunotherapy, and we'll come back to that later.